All right, hey everybody, come on in. We are going to be doing a fluid and electrolytes crash course today. So this is pretty typically horrible for students. They hate this concept. It's not something that they like doing at all because they don't understand it. So our hope for today and our goal for today is to make sure we present it in a way that is understandable, in a way that's easy to remember, so that way you don't have to study it multiple times. Okay, do not try to memorize signs and symptoms with fluid and electrolytes because they will get mixed up in your head and you won't remember them. So today we're going over big conceptual things about fluid and electrolytes and not just giving you a bunch of signs and symptoms, all right? So as you guys are coming in, I want you to tell me where you're from, what school you're from, and kind of what state you're from, because we have people that are going to be joining us from everywhere in the US today. And while people are coming in, there is a little bit of a delay. So if you guys have a question, you are more than welcome to type it into the comment box. And as soon as that pops up on our feed, I've got Tyler here working with me today, and she's gonna read the questions out so we can make sure that we get your questions answered. So while people are coming in, I'm going to answer a couple questions that we've had people ask a lot over the past week, which is, who are you and what do you do? So my name is Amber Brown. I'm the owner of Ivy League Tutoring. We are a tutoring school for nursing students in League City, Texas, which is about halfway between Houston and Galveston. We not only offer in-person sessions here at our office here, but we offer Skype sessions, FaceTime sessions with students all over the country in nursing schools everywhere. So the three biggest services that we offer is usually what we have people ask. One, we have individual sessions. So if you're the type of learner that only learns with one other person, we set you up with a tutor that can teach you in a way that you learn best. You'll send us whatever topics that you need covered for your next exam, and your tutor will set up a tutoring session specifically for you. And you can sign up on our website to do that. We have nurse tutors that are experts in their field. So we have OB nurses, we have cardiovascular nurses, we have ICU, pediatrics, we kind of got it all. So that way you're sure to get the education in a way that makes sense to you and from a nurse who is an expert in their field. All right, so that's one, is the individual sessions. Number two is our group sessions. So we do group sessions here in person if you are in nursing school local, but we also do group sessions all over the country. So get a couple of people together from your nursing school. You guys have an upcoming exam on a topic you're not understanding. Get them together. We'll either Skype or FaceTime with you, and we'll pick a nurse tutor that's an expert in that area, and they can do a customized 2-hour session just for you, okay? The third big thing that we have is our videos on demand. So if you like what we're doing today, one thing I would encourage you to do is to go to our YouTube channel and subscribe. We have tons of free videos there on infection precautions and tuberculosis and DKA. We also have another fluid and electrolytes session that talks about sodium potassium balance. We have one on Cushing's and Addison's, and those are all free for you to watch. So if you go to our YouTube channel, you can check those out. We also have videos on demand. So if there is a topic in nursing school that you're covering and you really want this kind of dynamic and this kind of teaching, we have a full video series of videos on demand, and you can go and purchase those straight from our website. So let's say you have an upcoming pathophysiology exam in cardiovascular, we've got a topic for that. If you're preparing for ATI or HESI, whether that be an exit exam or a PEDS exam or an OB exam, we have reviews for every single one of those with the most testable content in that area, okay? So with all of that said, we've also just launched our new NCLEX prep course that is completely online. There are over 20 review videos and 20 different classes that you'll take online. It also talks about test taking strategies and how to set up your study plan. We have a 100% pass rate. We're super proud of it. We just launched it, and that's available for purchase on our website as well, okay? So with all of that said, I'm gonna have you guys kind of come in and let me know where you're from, and then we're gonna get hitting on fluid and electrolytes, okay? Brittany's here?
Yes, from Huntsville, Target, we have a lot.
All right. Oh, Shireen's back. We know her. All right, Kevin from Texarkana. Awesome. We got some people from some Texas people, which is fantastic. And Melissa from below. All right, so are we ready to get started? I want you guys to kind of tell me what your biggest problems have been with fluid and electrolytes in the past. Let me know the biggest struggles that you've had so we can make sure that we hit or try to hit most of those today. What the goal of today's session is to talk about the balance of electrolytes in the body and where they're balanced. And then we're going to go over these 4 major electrolytes and talk about signs and symptoms of each and make sure that it makes sense pathophysiology wise instead of just trying to memorize weakness, lethargy, tremor that nobody ever remembers. Okay? So give us your biggest issues, and we're going to go ahead and hit those today, and then we're going to get started with electrolyte balance. Okay? All right, so Marie says she has trouble with signs and symptoms. We're definitely going to do that. Yes, we're going to talk about some fluid balance. Okay? And then after we're done today with this live, we will post it on our Facebook page, and then it will be available within the next week or so on our YouTube page for you guys to watch as many times as you want to, okay? So with that said, are we ready to get started? Dum, dum, dum. Okay, lab values, ABGs, signs and symptoms. So basically, nursing school is what is what we're needing, right? All right, so if you guys are ready, all right, telling them apart from each other, yes, we're definitely gonna do that today. So the first thing that I want to talk about is electrolyte balance, okay? People typically think electrolyte balance is just in the kidneys, and it isn't. Electrolyte balance happens everywhere in our body. So if you can understand the different seesaws of the electrolytes, you're gonna be able to ace this. It's gonna make it so much easier. So what I did today was I put up 4 different places that your electrolytes can be balanced, all right? And we're gonna do 4 different seesaws in each of those 4 boxes. That means that as one of these electrolytes goes up, the other one typically goes down, and vice versa. And that's gonna really help you when it comes to treatment of hyperkalemia or hypokalemia, hypercalcemia, hypocalcemia. All you have to do is match up the seesaws, all right? So with that said, I want you guys to tell me, since you can see the 4 boxes, what 2 electrolytes are balanced in the kidneys, what 2 are balanced in the heart, what 2 are balanced in muscle, and what 2 are balanced in parathyroid. I'm gonna give you guys a few minutes, write me down what you got so I can see what you know.
I was just gonna write down what they're saying for the questions.
Oh, sure. All right, Anna said something about the dreaded ABGs. We do have a video on ABGs on our YouTube channel, so definitely you want to check that out. All right, so we got some people coming in telling us where they think these electrolytes are balanced. All right, so if it's, I don't know if it's Anna or Anna, I hope I'm saying it correctly. She's talking about calcium being balanced in the parathyroid, kidneys. Ariel says kidneys are potassium and sodium. All right, so you guys got some stuff going on. Here we go. All right, so the kidneys, this is typically the biggest one that people think of whenever they think of electrolyte balance. So the 2 that we're gonna have in the kidneys are potassium and sodium. Now this is almost always a balance between the 2. There are a few exceptions where you may actually see hypernatremia and hyperkalemia, and this is almost always a kidney problem, or it is going to be an adrenal problem since the adrenals sit right on top of the kidneys. We do have a free YouTube video on Cushing's and Addison's. That would be a fantastic one for you guys to check out as far as fluid and electrolytes as well, because that's gonna happen. But most of the time, if you're going to dump potassium, then your sodium's gonna go up and vice versa, all right? The reason why this is important for you to know is because if we have a patient with hyperkalemia and we're looking for treatment, well, if I know this is high and this is low, if I could bring this up a little bit, it would balance us out, which is why if you have hyperkalemia, one of our antidotes for hyperkalemia is to give sodium bicarb, which would make sense because if you increase the sodium, then that potassium is going to decrease a little bit. All right, in the heart, these are really important, okay? So, I saw a couple of people say it. This is going to be calcium and potassium. So calcium and potassium are highly regulated in the heart, okay? And if there are imbalances with calcium or potassium, what's gonna be affected? You're gonna have dysrhythmias, all right? What about, let's do the parathyroid. People always forget about this poor little organ. So it's located behind the thyroid, has nothing to do with the thyroid other than location. So that's why it's called the parathyroid. Parathyroid's job is not metabolism, it is actually balance of electrolytes. And the 2 that are balanced there is calcium and phosphorus, okay? Phosphorus is like the forgotten electrolyte, which is why we don't mention it here. It's like the black sheep of the family. You're not gonna see a tons of signs and symptoms with high or low phosphorus, but it can affect your calcium pretty significantly, which is why we're mentioning phosphorus today. In the muscle, okay, so our muscle ones are magnesium and calcium. Those 2 typically have everything to do with muscle, but also calcium does have a little bit to do with the heart as well, okay? And you'll understand that a little bit better as we start going through each of the electrolytes. All right, so how many got it right and understand kind of how this works? All right, so let's take a look. If we talked about hyperkalemia here, and we can fix hyperkalemia with sodium bicarb, if we look right here and we know we have hyperkalemia, what other thing can we use to fix hyperkalemia if we want to do it without using Electrolyte? I'm going to give you all a few minutes, okay? All right, who knows? I know it's going to take a minute for you guys for it to catch up a little bit. Y'all know? Come on. Somebody's got to know. All right, Anna says calcium equals cardiac issues and heart is a muscle. Absolutely. So heart and muscle are going to be very much intertwined. Okay. So if we have hyperkalemia, we can either treat it with sodium bicarb, or if we look down here and we have hyperkalemia, we can treat it with calcium gluconate. Okay. So that if we gave the calcium gluconate, that's going to even this out and hopefully bring down our potassium a little bit. All right. If you notice, calcium is a little bit important, all right? So we're gonna talk a lot about that and how that works, all right? So the next thing that we're gonna do, if you can understand where these are balanced and you can understand what they're balanced with, it will make more sense whenever you're looking at treatment, right? For instance, if we have a patient, let's say patient's in complete kidney failure, all right? If they're in kidney failure, is this balance going to work? No. So my normal balance of sodium, potassium isn't working and I'm not peeing at all, right? So if the patient isn't peeing, then they can't really get rid of potassium or sodium. This is one of the only instances when both of them will go up, right? So if I know that both of these are going to be elevated, okay, and does anybody know what vitamin is produced or helped to be synthesized by the kidneys? Because that's going to come into play when we talk about our electrolytes. Which vitamin is synthesized by the kidneys? So if my patient's in kidney failure, I'm going to have a problem. Who knows? Somebody came through with vitamin D. That is absolutely correct. So vitamin D has to marry with calcium in order to make those work. So if vitamin D is not being synthesized, it can't marry with calcium. Therefore, our calcium level is going to be low, right? And if we know that this is a balance in the parathyroid, then our phosphorus level is going to be high, which is why in kidney failure patients, we give them a drug that's a phosphate binder to help get rid of this phosphate. So all you have to do is follow the electrolytes through and they really make sense instead of trying to memorize kidney failure causes hyperkalemia, hypernatremia, hyperphosphatemia, and hypocalcemia. You'll get it mixed up on the exam. But if you can start with the basics and follow the electrolytes through using your seesaws, it will be so much easier for you to figure out which electrolyte imbalance they have and then what the treatment looks like, okay? So if I know the patient has hypocalcemia and chronic kidney disease, I'm gonna give them calcium. But giving them calcium isn't gonna help me if I didn't also give them vitamin D, right? So they're going to be getting vitamin D, they're going to be getting calcium, they're going to be getting phosphate binders, and then we're going to be watching for signs and symptoms of hyperkalemia and hypernatremia. So I just use that as an example to show you that this is the way you study instead of trying to memorize all of the signs and symptoms. Follow the patho through, and it makes a whole lot more sense, all right? So what we're going to do next is we're going to go over the big four as far as electrolytes, okay? We're going to talk about big keywords that you can use to remember imbalances, and then we're going to talk about the different signs and symptoms and how they work, not by memorizing. Now, you'll see some mnemonics that are cute, like cats and things like that, and they can help you, but you've got to understand the patho behind them, and then you'll never forget them, all right? So the first one we're going to start out with is sodium. So I want you guys to tell me, what do you know about sodium? What organ does it typically affect? Why do we need it? Just tell me what you know. You gotta love me some salt. Come on, y'all. Tell me what you know about sodium. Okay, Marianne with 135 to 145 is normal. Beautiful, that's correct. And I'm going to write that up here while you guys are chatting. So sodium normal level, 135 to 145. That's normal level. Okay, what else you guys got?
Affects neuro.
And neuro, that is the biggest thing I can tell you about sodium. Now here is something not to get confused about and where people do get confused. These are where they are balanced. okay? It doesn't always mean that that's where the signs and symptoms are gonna be. Sodium, potassium are balanced in the kidneys, but you don't have kidney symptoms with sodium or potassium. They affect different organs. Now, if you go and watch a fluid and electrolyte video we already posted on the YouTube channel, we go into major detail about sodium and potassium and that exchange, so you can definitely watch that as a follow-up. But today we're gonna talk about how these work. So if we know that sodium typically affects neuro, that is our big keyword. So anytime you see hypo or hypernatremia, brain, okay? You're always looking for brain symptoms, okay? What do I mean by that? We're gonna talk about low sodium and high sodium and kind of what you see with each of those. All right, so if low sodium is called hyponatremia, right? If we said that this affects brain and it's neuro, let's talk about our neuro symptoms. Does anybody know what signs and symptoms we see from the brain that can be caused by low sodium or high sodium, and why?
Someone said seizures.
Seizures is one of them, absolutely. All right, determines fluid volume because sodium and water are gonna kind of go together, right? So we know that this fluid balance is really important, okay? With either high or low sodium, it's always gonna end up with cerebral edema because fluid is either gonna rush into the cell and rupture the cells, or it's gonna rush out of the cell and cause the brain tissue in that interstitial space to swell, okay? So either way, sodium, brain, always looking for brain symptoms, okay? So for low sodium, which is hyponatremia, which would be less than 135, tell me some signs and symptoms I might expect to see other than seizures, which I will write.
They have thirst, lethargic, loss of consciousness, or decreased level of consciousness.
All right, so we've got neuro symptoms like seizures, headache, coma. These are all brain issues, yes? Confusion, dizziness, because our fluid balance is off in the brain. Do we understand? Okay? So we're going to see all neurological signs and symptoms. Now, if you look at high sodium, so sodium greater than 145, you're going to see the same kind of brain symptoms, okay? We're still going to see headache, seizure, coma, or death, okay? So headache, seizure, coma. Because either way, the end result, if we get too much or too little, the end result is cerebral edema. The brain's going to swell because the fluid balance is not right, okay? So we get headache, seizure, coma. We can also get lethargy, which is another neuro symptom. Now, the only thing I would add with hypernatremia is to think of how you feel when you have eaten a ton of salty food. We all been there, crying over Netflix, sitting there on the couch trying to neglect studying, and ate an entire bag of pretzels. Yep. I ate 6 TV dinners because I was trying to be healthy, and then I got hungry again, so I just kept eating them. When you have a lot of salt, how does your mouth feel? It gets really dry and you get really thirsty because you've got too much salt, and that tells your body, oop, you better water this down, and we get thirsty. So we can also add here dry mouth and thirst, okay? Now if you want to look, we weren't going to talk much about treatment, but I want to go through quickly and show you how you can do treatment so super easy. If you have low sodium, how do we fix it? We give you sodium, but please be careful. Let's not just give them like a salt lick, okay? Anytime you raise or lower sodium, salt, or sugar, either one, we have to do so slowly because you have to think there's a huge fluid balance problem here, right? So if I give them a ton of salt all at once, all that water is going to be attracted to it and we're going to cause more problems. So salt and sugar both have to be lowered slowly. Let me give you an example. When a patient is in DKA and their sugar is super, super high, right? Diabetic ketoacidosis, super high. We're going to give them normal saline, right? So that is going to help to dilute some of that sugar a little bit and give them fluids because they come in dehydrated. But once they get that sugar down to 250, we switch to a dextrose 5% solution. In nursing schools, I was like, why would you give them sugar if their sugar's high? Because you can't decrease sugar or salt too quickly or we cause more brain symptoms, all right? So if I'm going to fix a hyponatremia, if it's severe, we could give a hypertonic solution like normal saline 3%. Even then, that has to be given super slowly because remember, we don't want to shift too quickly, okay? So hyponatremia would be treated with a hypertonic solution. By low salts, hypertonic means high salt. Low salt, give high salt, okay? If you have high salt, guess what you're gonna give? A hypotonic solution, okay? So that would be something like half normal saline, okay? So we're gonna dilute that, have them drink water if they're conscious, all right? So do we understand how sodium works? It is neuro, it is brain. We will do it slowly. Does everybody understand or have any questions, all right? That one's easy. It's almost always gonna be some brain symptoms, yes? All right, next one is going to be our potassium, okay? We know sodium and potassium are gonna go on a seesaw, right? Okay, so they are balanced in the kidneys, but potassium is what's responsible for giving us that action potential. So potassium moves, it contracts, it does things, okay? So remember that when we start talking about low or high. Potassium, boom, does things, okay? What are our keywords, you think, for potassium? What are the two biggest things that potassium works on? Or what should our keyword be? Like with sodium, it's brain. What about potassium?
Heart.
Heart is number one. What's the other one? Potassium messed up will mess up our pump. True story. All right, so we know cardiac. What's the other one? The heart is a what? Okay, normal level 3.5 to 5. Okay, that is true. So we can write that up here while you guys are still answering.
Mary said muscle contraction.
There we are. All right. So with potassium, it is mostly heart. So I'm going to do a big heart here. But also a little bit of muscle because our heart is a muscle and it does have some muscle contraction things that it does. All right. Anytime on your nursing exams or on NCLEX, if they ask you something about hypo or hyperkalemia, the first thing you better be checking is that EKG because it's going to cause some dysrhythmias. If potassium gives us action potential in the heart, that's going to make the heart pump. Yes?
Didn't you say where the electrolytes were produced doesn't necessarily mean where the symptoms are going to be?
Absolutely. So just because they're balanced in an organ does not mean that's where we're going to see the signs and symptoms. So for instance, in the kidneys, the potassium and sodium are balanced in the kidneys, but if we have abnormalities of the brain, of the sodium, that's going to lead to brain issues. If we have abnormalities of the potassium, it's going to lead to heart and muscle issues. Mostly heart, a little bit of muscle. And then for calcium, we'll flip-flop that. All right? So potassium, we know that it's responsible for an action potential, right? And that action potential makes my heart beat. So if I have hypokalemia, I'm not producing a lot of action potential, so my heart's just going to do like that. Okay? If I have hyperkalemia, that's producing a lot of action potential, and you're going to be like crazy. Okay? So heart should be the first thing you check when you have a potassium problem. Okay? Also a little bit of muscle. Okay? All right, so let's talk about high and low. Give me some signs and symptoms you know of hypokalemia. Think about the action potential and what it's doing. All right, so some people are talking about pulse and DTRs and dysrhythmias, muscle spasms. All right, you guys are getting it. Here we go. So if potassium produces an action potential and I have low potassium, it's not producing any action potential. So your body just kind of is like blah, like it's not contracting any muscle, right? So therefore, it could lead to full and total cardiac arrest because your heart's like, nah, I'm good. I ain't got no muscle to contract, okay? So we can get cardiac arrest, major dysrhythmias, right? So first thing I'm gonna do is check that EKG. Now, does anybody know what EKG changes will happen with hypokalemia and what EKG changes will happen with hyperkalemia? You guys can answer that while I keep going on signs and symptoms. Hypokalemia. So since there is very little to no action potential, then your muscles are just like laying there, right? So we can have cardiac arrest where your heart just gives up on life. And then dysrhythmias where it could just, it doesn't beat correctly, okay? We're gonna get weakness, right? Because there's no action potential, yeah? Or there's little action potential. We're gonna have lethargy because I just can't today. What do you think is gonna happen to our DTRs, deep tendon reflexes, if our muscles are not doing anything? DTRs are probably gonna be a little decreased, yeah? That's the part of the muscle portion, right? Big hearts, little muscle. What do you think is gonna happen to my gut muscle if nothing is moving? So if there's nothing to action potential, there's nothing moving, I'm gonna get constipation, okay? Now, keep that same concept in mind, and I want you guys to give me signs and symptoms of hyperkalemia. Now we have too much action potential. We're too excited. Ah! Okay, now what happens? Now all of my muscles are going to be going insanely crazy. Yes? So therefore, still, since it's big heart, little muscle, I'm still going to have dysrhythmias, right? Your heart's going to be like super excited, okay? There's like too much going on, and so you're going to have some major dysrhythmias. Now all of my muscles are going crazy with all this action potential, so I can get muscle cramping. What else are you guys going to see? Did anybody else answer?
Tachycardia.
Maybe, but more so dysrhythmia. So it's going to be disorganized electrical activity because the action potential is kind of going crazy. What else we got?
I said diarrhea.
Ah, so if my gut muscle is going insane with all this action potential, we definitely can get diarrhea. Okay, anything else? Think of my muscles are going to be twitching and cramping, right? So we may get some twitches in the muscle. Now, does this make sense? Mostly heart, little bit of muscle, all right? So we know what signs and symptoms we're looking for and what to expect. Now, if I have hypokalemia, we have to check our comp meds, our metabolic panel, because I also could have hypernatremia since they go on a seesaw. Or we could also check this way. If I had hyperkalemia, we want to check and make sure I don't have hypocalcemia. Okay? So the seesaws work beautifully with your signs and symptoms.
A lot of people are saying like VFib and things like that, but that is more so associated with dysrhythmias overall,
yes,
correct?
So you can do like VFib. Those are our dysrhythmias where our heart is super, super excited, okay? So you more so would see that with our hyperkalemia, right? So dysrhythmias, yes, they're just listing the specific dysrhythmias, which is great. You get A's for today.
That was confusing to me because dysrhythmias are essentially the same thing as those
yes,
terms.
so a dysrhythmia is a huge term that just means like your heart not pumping right, okay? So you may see VFib, but up here with hypokalemia, because there's not much action potential, you wouldn't see your heart super excited. You may see severe dysrhythmias with bradycardia, you may see poor cardiac output, and then eventually cardiac arrest.
Someone said to explain the seesaw a little bit again.
On this one?
Yes.
Okay, so since the potassium and sodium are balanced in the kidneys, if you have hyperkalemia, so your potassium is high, we have to check and make sure you don't have hyponatremia and vice versa. Those go on a seesaw. So if I have hyperkalemia, one of my antidotes is sodium bicarb. As I bring up the sodium, the potassium evens out. Same thing here. If I find out a patient has hyperkalemia, okay, and we need to fix that, we need to bring it down so we can stop these dysrhythmias, we'll give them calcium gluconate and that will even that out. It'll bring down your potassium and increase your calcium a little bit. So this not only helps us to look for potential problems, it also gives us our treatment, which is beautiful, okay? All right, so now that we've done potassium, let's do calcium. This is a big one. Tell me what's your normal calcium level, okay? I want you guys to tell me what you know about calcium in the body.
The other thing for the EKG, what would it look like in the potassium?
Oh, yeah, okay, so to come back to what would the EKG look like? This is super easy to remember. Anytime there's an abnormality of potassium, it's always going to be your T wave that's affected. Low potassium, we usually have an inverted T wave. High potassium, we have a peaked T wave. So if you think that your patient has an abnormality of potassium, or you know that they do, check the EKG and watch that T wave, because that will tell you what's going on in the electrolyte imbalance. Okay? One of the only times in nursing school where like everything actually matches up beautifully is on that EKG. High potassium, peak T, low potassium, usually inverted. Okay?
What is it in AKI? I know we're talking about the heart, but in AKI there's something with the U wave. So would that be hyper or hypo? Someone commented that.
In AKI and in CKD, the potassium level is high. You won't always see a U wave, but sometimes you will. Okay? All right, so let's go on to calcium. What do you guys know? All right, so we know that calcium is usually somewhat associated with bone, but not really. But if you did break a bone, who would you call? 911, which is your level for calcium, okay? Now we talked about potassium being big heart, little muscle. Calcium, let me find a new color. Let me use the same so that way you remember. Big muscle, little heart, because these are on a seesaw in the heart, so that makes sense. I'm gonna draw a tiny little heart down here, but mostly it's muscle, okay? Easiest thing to remember about calcium and how to keep it straight. Calcium in and of itself is lazy, okay? So, if calcium is lazy, and we have low calcium, that means that we're not lazy, okay? All your muscles are gonna be tight and crazy, right? Because they're not lazy. So, if I have hypocalcemia, I'm gonna have major muscle, a little bit of heart, so we know it's gonna be muscle issues. We know it's not lazy, so it's gonna be tight muscles. So you're going to expect to see things like tetany, right? Muscle spasms. Muscles are going crazy if the calcium is low, okay? So tetany, spasms. What else are people yelling at me?
Positive trousseaus.
Yes, we're going to talk about trousseaus and chevosic, the other one that people hate, okay? We're trying to remember the two. So positive trousseaus, positive chevosics, okay? We can also have seizures, which is part of kind of muscle and that action potential, okay? And then we said too that it's a little bit of heart, so we're also going to add dysrhythmias onto here, but we're going to add it on the end because it's not quite as much as when we added it up first with potassium, okay? So the easiest way to remember chevosics and trousseaus. For chevosics, we're going to flick the cheek for chevosics, and they're, I know, I'm not really, it'll help you. So their cheek is going to spasm, okay, whenever we kind of do like a little, don't do it hard because that's mean, okay? Just do like a little thing and it'll make the muscle contract on their cheek, okay? Trousseaus, you put a blood pressure cuff on their arm and you blow it up pretty tight. When you do that and the patient has hypocalcemia, can you see my hand? Okay, then their hand is going to cramp up into a sign language T for trousseaus. Their hand will look almost exactly like this, okay? That's a trousseau sign, okay, as my muscles start cramping. Somebody check my muscle down. I know. All right, so that's hypocalcemia. So mostly muscle, tetany, spasms, trousseaus, chevosics, seizures, a little bit of heart.
What about
yes.
Increased DTR?
Increased DTRs, yes. Because if we are doing tetany and spasms and those kind of things, absolutely we can have increased DTRs. Anything else I missed?
No, just a question asking if a picture of all of this will be posted.
Yeah, we can do that. Yeah, absolutely. We'll post a picture after we're finished. Okay, so look in the comments because that's usually where we'll leave it. All right? All right, if I have high calcium, so we said calcium in and of itself is lazy, right? So if I am increased and I am extra lazy, so your muscles are going to literally be like, kabooh, okay? Think of it like the 35-year-old that still lives on mom's couch. He can't do anything, okay? He's just laying there, right? So therefore, if this is muscle and everything is just not doing anything, then this is muscle weakness. What else we got? Y'all hit me. Tell me what else you got.
So far, just muscle weakness.
Muscle weakness. What else are we going to see? Think about your muscles in the gut. If those are super weak and not really moving, you can get constipation. We got a question?
Yes. What is the acronym for DTR?
Deep tendon reflexes. Very good question. Okay, so since those are a muscle reflex, and we know that in hypocalcemia, our muscles are whoop and tight, then your DTRs will be increased. So be careful. If you know that a patient has hypocalcemia and you go to do their DTR, their deep tendon reflex on the knee, watch out, they'll kick you in the face because their deep tendon reflex will pump right up. Okay, so watch out. Nobody wants a bloody nose. That's a Grey's Anatomy moment. All right, so if our calcium is increased, so that means that I'm super lazy, all of my muscles just kind of blah, okay? So you're gonna have muscle weakness, my gut's gonna be slow and the muscles aren't moving, so I may get constipation, right? We can have lethargy. They're just, bleh. They just really don't wanna move or do anything. We're gonna have fatigue. Now what do you think is gonna happen to my DTRs here if my muscles aren't really moving? I can try to elicit them, but I'm probably not going to get very much. Some people are saying decrease. That's absolutely correct.
Absent ones sometimes.
Sometimes even absent, absolutely. So you're going to have to try for a little bit to try to elicit those deep tendon reflexes. All right? That's how calcium works. All right?
People keep bringing up renal calculi, which is good, but not a symptom.
That one's kind of tricky because the most recent research has come out saying that hypercalcemia does not lead to kidney stones. I know that's where y'all are going with that. That's something you'll have to talk to your instructors about. They very recently came out with that and said, hey, having too much calcium does not bind them up and make stones. I've seen some places that are still teaching that, some places that are not. So I would absolutely ask your instructor about that. They have now said that there is no link, and this is all I can tell you on the research, between a high calcium diet and the increased risk of calcium kidney stones, okay? All right, so we understand calcium, mostly muscle, a little bit of heart, all right? The next one, or the last one we're going to go through, is magnesium. People kind of forget about magnesium, but for whatever reason, the NCLEX loves magnesium. Nursing instructors love magnesium, and nobody ever talks about it. One of the great things is, though, that magnesium is, there's tons of magnesium in chocolate, so now is the time to go ahead and start binge eating the chocolate so you can make sure. Most people are probably like, yeah, I've already been taking care of that. All right. Now, bear with me on this one because this is interesting and kind of cool. And I used to not even add magnesium up here, but I do now to make people more comfortable. But listen, calcium and magnesium do go on a seesaw, but magnesium is kind of a weaker electrolyte, so you're not going to see like high calcium with super low magnesium. You're just not going to see that. Their seesaw is very subtle, okay? However, the signs and symptoms of low and high calcium are the same or very similar to high and low magnesium. So if you don't even want to look at it, just don't look at it and be like, calcium the same, okay? Because watch this, all right? If we do, let me find a different color. Hold on. Okay, I'll do brown for the chocolate that we're going to eat after this is over. All right, so if we do high and low magnesium, okay, magnesium is mainly going to be muscle. It does very little with the heart. So that's one of the only differences you're going to see, all right? But hypomagnesemia, what do we usually see? Tetany, paresthesias, muscle, yes. We can typically get increased DTRs. Is this starting to look somewhat familiar? Okay. Most of these signs and symptoms are parallel to low, or to these opposite, are parallel to the low, okay? So they're the same. If we look at high magnesium, which doesn't usually happen in our body is very good at getting rid of it. But if we look at signs and symptoms of high magnesium, we're gonna see maybe a little bit of increased DTRs, okay? We may have a little bit of hypotension, and why would that happen? We talked about in calcium, if everything gets lazy when it's high and everything's lazy here. Oh, this should be decreased, shouldn't it? There we go. Thank you. Decreased DTRs, hypotension, so everything is still lazy. So if you don't want to even look at this, that's okay. That's what I did when I was in nursing school. All I did was remember all the signs and symptoms for calcium, and I knew that magnesium was so close. So it's almost exactly the same.
Marie said muscle, think moms because it's used for contractions.
Oh, very good. Absolutely. So magnesium, muscle. All right. So hopefully this makes things a little bit easier. We will post a picture of this. Walk through your patho. I cannot encourage you to do that enough. Okay. Understand the signs and symptoms instead of trying to memorize them, because I promise you, you won't remember them forever and they'll go. Okay. Especially by the time you get to NCLEX. So know this chart and be able to walk through the patho. If you can explain it to somebody else and do it correctly, then you know that you actually understand the signs and symptoms and you get the fluid balance in the body, okay? So let me do a quick practice question so we can kind of figure out if we are understanding everything that we have done today, okay? So let's say, give me at least 3 antidotes for hyperkalemia. 3 antidotes or 3 medicines that we would give if your patient had a potassium level way greater than 5. And you'll use your seesaws for this answer. Okay, and also Rocky said respiratory depression with too much magnesium. Of course, why would that happen? That's a good point. If everything is getting really lazy and your lungs are a muscle, your muscles are not going to move very well, which means your lungs aren't going to move very well, therefore respiratory depression can happen. So it makes sense if you walk through the patho, yes? All right, I said at least 3 antidotes for hyperkalemia. All right, somebody said Electrolyte, which is the true antidote, sodium bicarb, and calcium gluconate. So if this is high, fix them with this. If this is high, fix them with this. And then Electrolyte actually is a drug that we give that helps us to get rid of our potassium through the stool, okay? So somebody asked for a quick recap, so here we go. All right, there are 4 different organs, and there are more, but these are the biggest 4, that are balancing the electrolytes. Just because they're balanced in the organ does not necessarily mean that's where you're gonna see signs and symptoms. In the kidneys, we have a balance of sodium and potassium. In the heart, we have a balance with calcium and potassium. In the muscle, we have a balance of magnesium and calcium, and parathyroid goes on in the parathyroid balances calcium and phosphorus. So once you figure out what your electrolyte imbalance is, you're going to match it up with its keyword. If it's a sodium problem, you're going to look for brain issues. If it's a potassium problem, you're going to look for mostly heart, little bit of muscle symptoms you may see too. Calcium, mostly muscle, so you're going to flip this, little bit of heart. Magnesium is almost always muscle. Calcium and magnesium mirror each other as far as signs and symptoms. All right? Hopefully that's super easy for you guys to learn and understand. We're going to take a picture of this and post it. We're also going to post this video onto the Facebook page for a short period of time. Be sure to go over to our YouTube channel and subscribe because we will be posting it onto the YouTube channel as well as all of our other fluid and electrolytes videos and nursing school videos, so that way you guys can tune in with us, okay? For today only, if you like the videos, if you like the way that we teach, we're going to be offering 25% off our videos on demand today only. So if you go to our website and click book now and then click pre-recorded videos, you'll be able to see our entire video library. Stay tuned for just a few minutes and we're going to post the promo code for you to get 25% off any of our videos today. All right. So I hope you guys had fun with fluid and electrolytes. I know it can be really tough, but hopefully it made it a whole lot easier for you. Feel free to ask us any questions in the comments and we will have our staff answering those. All right. You guys have a good one.